My task was to talk about peri-interventional anticoagulation and antidotes. There we go. This is my disclosure statement. Obviously, you all know this spreadsheet. This is something that Hein Heidbichler already put up in his very first version of the EHRA guide back in 2013. Hasn't changed since, even in our latest version. Yet we have to admit the evidence base behind this has changed quite dramatically and is in the process of changing. This is obviously, for dabigatran, renal function is factored into our recommendation, whereas for the 10A inhibitors, there's really no big differentiation based on renal function, at least down to 30 milliliters per minute, as when to stop or when to take the last dose of an anticoagulant prior to an intervention or a surgery. Now, with that being said, from 2013 to now, there have been new trials that have surfaced and that are partially underlining and partially challenging this concept. Now, one of them, of course, is Bruce Control 2. Now, Jeff should be the one obviously presenting this. He was prominently involved in this. One of my favorite acronyms, by the way, Jeff, congrats on that as well. Bruce Control, I think it's terrific. And Bruce Control 1, as you know, was the one with the uninterrupted and warfarin therapy around device surgeries. Bruce Control 2 now took a look at patients on NOACs, namely dabigatran, rivaroxaban, and apixaban, and looked at both a continued arm where the pre to post-operative DOAC dosing was around 12 hours versus an interrupted arm where the median was around 72 hours of interruption. And it turns out there's no big difference between the two arms, number two, and also number one, and number two, the event rate, and the primary endpoint here was significant hematoma formation is low. It's around 2% in both arms. So sort of underlining, or at least partially confirming our notion to, if at all, interrupt only briefly around cardiac device surgery. There's another trial also from Hamilton. Jim Duquetis was nice enough to share his slides with me because obviously this has only been presented at the ASH meeting last year in December. It's not yet out. It's not yet published. The PAUSE trial, so perioperative anticoagulation used for surgery evaluation. This was actually quite a nice design in that for all NOACs, available NOACs at the time the trial was performed, so apixaban, dabigatran, depending on renal function, and rivaroxaban, there was a clear-cut scheme as to when to have the last dose taken, depending on whether your surgery was high risk or low risk. Then the intervention was done, and then there was also a clear-cut scheme as to when to restart afterwards. And the results, as I said, were presented at the ASH meeting last year, and they look pretty good. On the one hand, we have to admit that we are not going to expect a 0% event rate in these patients, neither for ischemic events nor for bleeding, because obviously these surgeries are performed on a background risk of events, both ischemic and bleeding. And so when we compare the event rate that was observed for the 3 NOACs that were included in this trial, both for arterial thromboembolism as well as for major bleeding, it was well within that range, what was observed. I can't show you much more. I cannot, because there's not much more available. We'll have to wait until the publication of the trial, but this was looking very confirmatory. Now, the other part that was interesting with respect to the PAUSE study was that they actually also took plasma levels of NOACs prior to the surgery, and this is something that has been sort of something we had a little bit of blind spot for in the past, because NOACs obviously were developed without the need for plasma level monitoring, and nevertheless, this is not monitoring. This is just assessment of NOAC levels. So really to check what were the levels that were encountered based on these schemes that were used in the PAUSE study. And in fact, it turns out that if you take a NOAC level of 50 nanograms per milliliter, which is very low, actually 30 is considered the very lowest, almost 99% were at that level at the time of device surgery. And this was true for all of them, as a matter of fact, including dabigatran and the high dose and rivaroxaban. So I'm saying this because this is something that we also put our neck out a little bit, as Hein always frames it, we'll stick out our heads a little bit and try and take it one step further, because we're confronted with a pretty much a similar situation as we had with low molecular weight heparins pretty much exactly 20 years ago, and also these drugs were studied without measurements of plasma levels or factor Xa activities, and nowadays we almost we dose drugs according to factor Xa levels. So we put this out for the first time in the guide, to see what are the expected ranges at peak level, at trough level of the respective NOACs. Not only around surgery, but in general. This is actually in the trials. So in RELY, Aristotle, Engage, and in Rocket AF, these were the levels that you would expect in the phase 3 or in the phase 2 trials at trough level. And these are much more reliable, as a matter of fact, than the standard coagulation assays. Now, with that in mind, of course, we have to admit, and this is a very important take home, of course, the vast majority of patients will not need this, but there may be situations in which it may be useful to have it. One of them is for our neurologists, for example, when somebody comes in with a stroke, and as we've heard, there is a residual stroke risk with NOACs also, but also around surgery, this may be something worthwhile considering, especially in the high-risk surgery patients. Now, one addendum I should add, the PAUSE trial did not include patients on edoxaban because it was not available at the time. However, on Tuesday, there will be the EMIT trial be presented here at EHRA, which is a dedicated edoxaban trial around elective operations. So this is now the scheme that we came up now in our new guide with respect to when to stop and how to dose these drugs. Of course, you all know this. I think two important aspects here. Once more, there's no need and actually no data to bridge these patients, and we're still seeing this also at my hospital. We get this once or twice a month that patients are being bridged with low molecular weight heparins. There's no rationale for this from a pharmacokinetic or a pharmacodynamic point of view, and in fact, any data out there that has looked at this, if anything, they show that there's an increased risk of bleeding and no further protection from stroke. So no rationale for bridging these patients. And then especially in the high-risk patients, to consider plasma level assessments to see where we're going. But of course, without any prospective data behind this. Now, switching gears, I was also asked to talk a little bit about antidotes. Of course, this was something ever since NOACs came almost 10 years ago to our clinical arena, something that we were afraid of, that were anticoagulating patients without a specific directly acting antidote. Of course, not ignoring the fact that we also didn't have that for warfarin. We still don't have it. We don't have a directly acting specific antidote for warfarin as well. There's vitamin K, which takes some time, and then there's a non-specific reversal with prothrombotic agents. Now, this has changed now with the NOACs. Of course, the first antidote that was available, that has been available for a while, is edorisizumab, specific for dabigatran, a monoclonal antibody that takes out dabigatran out of the equation. No matter if you're looking at patients with urgent surgery or with severe bleeding, takes out dabigatran from the equation almost immediately. You can see this a very dramatic reduction after the first and second vial of an infusion. It's a short infusion. Bolus infusion, there's no more measurable dabigatran on board. With that being said, that does not obviate the necessity for a differentiated use of different NOACs, because even with an available antidote, you can see that mortality, 30-day mortality in these patients is around 12%, 90-day 19%. And it's not because of edorisizumab, it is in spite of having an antidote available. These patients, once they have a severe bleeding event, they have a mortality which is much higher than the baseline mortality of these patients, so we need to keep that in mind. Just recently, the final trial for andexanet alpha was published. The final version of the trial was published. Andexanet alpha differs in many ways with compared to edorisizumab. It's mechanistically, it's a decoy. It's not an antibody. It's an inactivated version of factor Xa, which binds the Xa inhibitor and thereby liberates biologically active factor Xa. the mode of action. The other difference is the mode of application, whereas idursulizumab is given in 2 vials shortly, one after the other. Andexanet alpha is a little bit more complicated. You'll give it as a bolus followed by an infusion over 2 hours. And then there's different dosing regimens depending on which NOAC the patient is on. So a little bit more complicated to reconstitute. And also one other difference that is maybe not to be ignored, it is much more expensive with respect to what is anticipated. Right now it's in the order of 25,000 or 50,000 for the higher dose of andexanet alpha. Already idursulizumab is not a cheap drug. This is again an order of magnitude higher. These are the results. Dear Connolly presented this a while ago. This is the final version that was just published last month. You can also see that there is a reduction in the anti-10A activity for apixaban and rivaroxaban, the 2 NOACs which were in the trial. There was also an enoxaparin arm. You can see that it's not completely suppressed compared to what we observed in the reverse AD trial with idursulizumab, but also a substantial reduction, also substantial clinical improvement with respect to the clinical assessment of major bleeding. On the flip side of this, there was a certain incidence of thrombotic events within 30 days. This is along the lines of a possible prothrombotic effect of this antidote, which was not observed to that degree with idursulizumab. And also, and this is quite interesting, a very similar in the order of magnitude mortality after 30 days. So also here, we have to face the fact that having a severe life-threatening bleeding event under a NOAC, although the case fatality is lower than that with warfarin, it still is relevant even in the presence of an antidote, an available antidote. Also in Europe now, and you've probably seen this just 2 weeks ago, the EMA granted conditional marketing authorization for andexanet alpha. This will have to go to the European Commission to be approved, and then also in Europe, hopefully, it'll be available at one point in time. I think with all the limitations that we've seen for the antidotes, I guess it's good to have them, but I think we can at this point in time stick to what we wrote in our most recent version of our guide, that especially in the setting of life-threatening bleeding, this is really where those come into play. Obviously also keeping in mind that we do have data from the large randomized phase 3 trial that also the procoagulants, PCC, APCC also work for severe bleeding under 10A inhibitors. There's good data from ROCKET. There's also good data from the other trials that these drugs also work in NOAC-treated, 10A-treated patients. Which brings me to my summary conclusion. Perioperative management, I think we're moving into as little interruption as possible. There's the Bruce Control 2, there's the PAUSE trial, there's the EMIT data that we'll see that'll likely go in the same direction. We don't really know completely how to deal with high-risk interventions. There haven't been so many patients included with this, not even in the PAUSE trial, and we will have to further prospectively assess the role of plasma level measurements in this context. With respect to antidotes, they are available now. They seem to work well. There are differences with respect to mode of action, mode of application, and also cost between the two. And there is a residual risk, at least with andexanet alpha for prothrombogenicity. And we'll definitely have to keep an eye out for that, how this plays out also in daily clinical practice. So I think as a result of that, the use should be limited to the most severe cases as we have been proposing it. Thank you very much.